So 2 hours later, while at the private facility, she noted abnormally strong contractions that were persistent. And at this time, the attendants realized that something wrong and they demanded for referral to the General Hospital, to Kamuli General Hospital. She was then referred by the doctor due to failed induction as per the referral note on file for further management. On arrival at Kamuli General Hospital, that was about 14 hours, she had been referred from Bukung in the morning. Time was not documented. At around 14 hours, she arrived at her facility. She reported the above history of loss of fetal movements and misoprostol induction with 4 tablets, 2 sublingual and 2 paravagina. And she reported no history of draining of liquor, no any PV bleeding, but she was in excruciating pain and very agitated. At that time, we listed some history. She was a non-HIV positive mother on HER2 for 7 years. And she had 2 previous successful pregnancies carried to term, and 1 that was a spontaneous abortion at 8 weeks. She had been looking for a child since 2013 in vain until this recent one that she lost. Next slide. Her contraceptive history was not known. And family social, she was in a difficult relationship, multiple sexual partners, and was brought in by friends. Her husband, she's a peasant farmer, and her husband is a fisherman. And she reported that she neither smokes or takes alcohol. Next slide. On examination, she was restless, wailing in excruciating pain, febrile, had no pallor, no jaundice. Her BP on admission was 139/91 millimeters of mercury. Her pulse rate was 91 beats per minute. Her respiratory system, she was not in distress, and her oxygen saturation on admission was 97 to 99% room air. On abdominal exam, she had moderate distension with strong frequent contractions. At least we witnessed more than 6 in 10 minutes. And on palpation, she had general tenderness, either because of irritability or what. Everywhere was painful on palpation, but she had no GERD, no rebound tenderness. Fundal height was 39/40. She had no fetal heart on Doppler in all fields, and the fetal parts were not easily palpable. Per abdomen, fundal height was 4/5. A vaginal exam, vulva and vagina were normal, moist, had no PV bleeding, nor did she have active drainage of liquor. Her cervix was not effaced. It was posterior, and the presenting part was not engaged, but still very high. Our working diagnosis at the time of admission was a gravida 4 para 2+1 TRR DK known with IFD and uterine hyperstimulation with impending rupture. Our plan then was to do a full chemogram. Next slide. A take off blood for grouping and post-matching. We did an blood smear and syphilis. Those were for investigating for the cause of fetal loss. We also did blood group and cross-match. We requested to book at least 3 units of blood, and we plan to deliver by emergency cesarean section under the grounds of the hypertonic uterus and a big baby. Meanwhile, we established IV access. We started IV fluids, Ringer's lactate, and normal saline. We gave her nifedipine 40 milligrams start to at least reduce on the contractions. She also received ceftriaxone 2 grams start, and I also asked her to buy tranexamic acid 1 gram to be used after delivery, and metronidazole. Next slide. The Caesar was sanctioned at 14 hours. We also did the preoperative workup, consented for emergency cesarean section, we informed theater, and we catheterized. Our lab results was CBC HB was 11.7 and platelets were 153, and blood group was O positive, RDT was negative. The syphilis screen, we didn't have any results, and coagulation profile was not done. The patients were prepared for an emergency cesarean section, but we had a delay of about 2 hours because of lack of theater items, and the patients had to mobilize. Next slide. Next slide, please. A pre-anesthetic assessment was done by a senior anesthetic officer at 16 hours, that is about 2 hours from the admitting doctor's review. And at that time, the BP was 130/60 with a pulse rate of 109. She noted that there's no blood in the unit, and the patient was ASA stage 3E. And that one, I don't understand what it means. And she planned for a general malampathy. Yes, Dr. Agre. And the patient was with theater at 16:25 hours on 12th of May 2022, and the BP at the time of induction of anesthesia was 100/59 with a pulse of 111 beats per minute. It's important to note that between 2 p.m. and 4 p.m. there's no documented review on the file. Once that Caesar was sanctioned, people waited for the patient to go to theater. No reviews were done until the anesthetist reviewed. Next slide. On table, previous slide, the surgeon noted, found a massive, next slide, a previous slide, please, intraoperative findings. Behind, backwards. You have moved too fast. Again. Next slide. Next slide. Next slide. Intra-op. Okay, on table. Previous slide, please. Number 12. On table, okay, let me just talk about it. On table, the surgeon found a massive hemoperitoneum and an anterior rupture, and delivered an FSD boy about 3.8 kilograms, and the tear was repaired, hemostasis achieved. Intraoperatively, the BPs dropped and the patient was maintained on IV fluids and ephedrine. A patient left table stable, and the discharge BP of table was about 100. 109 out of 61 with a pulse rate of 99. Those are 2 slides behind. Immediate post-operatively, the patient was monitored closely, but sincerely. Go to slide number 12. Okay, so those were the intraoperative BP monitoring. Patient was stable throughout and was maintained on IV fluids and adrenaline drip. Surgery went on smoothly, the tear was repaired, and hemostasis was achieved as per the file. Next slide. Intra-op medications that were given as above. They gave atropine, ketamine, sax, ephedrine, and tranexamic acid. Patient was also given pitocin and about 3.5 liters of crystalloids, ceftriaxone, And the last BP at transfer out of theater was 106.64 with a pulse rate of 101 beats per minute and oxygen saturation of 99% at room air. Patient was transferred to the ward at around 18 hours. Awake with a BP of 127/70 and a pulse rate of 85. Blood transfusion was recommended, but there was no blood group O positive. It is also important to note that no estimated blood loss was documented on file. Next slide. Next slide, please. Next slide. Liz. She's off. Sorry about that, but Liz is not on over.
It has moved.
Next slide, please.
It has moved, doctor.
It has moved, okay. So immediate postpartum, the nurses did their work. They monitored the patient closely in the first 24 hours as evidenced on file, and drugs were given on time. Patient was stable and had no major complaints. However, there was no doctor's review thereafter until day 5. And on day 5, that was on the 17th of May, 2022, patient started leaking urine, and the urine bag had blood stains. The catheter was removed on attending doctor's advice and ordered to reinsert another one. However, the patient refused to be recatheterized, and patient had been switched to orals and requested for discharge against medical advice. So the patient was discharged home, but was cancelled about the VVF and how to.
I think Liz has gone off. Let me just share. She's back.
Oh, give me sharing rights. How do I do it? So as I had already said, on day 5, the patient started leaking urine and there's blood in the urinary bag. The catheter was removed on attending doctor's advice and was ordered to reinsert another one. However, the patient refused to be recatheterized and was switched to orals. A diagnosis of VVF was confirmed, and the patient was cancelled about care for the VVF and the personal hygiene. She was also referred to Kamuli Mission Hospital, which is currently having a VVF camp that is running. Started, I think, on Monday and is ongoing. Next slide.
Please, Dr. Susan, you share your screen. I've told her to unshare because the internet is disturbing her.
Okay. So how do I share?
Okay, then let me share.
Are you okay now?
No, for me, I'm okay, but it is Liz who has had issues.
Are you sharing?
Yes, let me share.
I can share my screen. Oh, let me share.
Fine, please do.
Let me share.
It's fine.
I have seen the icon. Am I sharing? Are you all seeing my screen?
Yes.
Okay, so we
Yes,
want
yes.
a post-operative slideshow. Where is slideshow? So as I was saying, the patient was discharged against medical advice, but was counseled about genital hygiene and care for the VVF, how to keep herself irrigated, and was referred to Kamuli Mission Hospital for VVF repair. There is an ongoing VVF camp. They usually have a yearly or annual VVF camps. So it is ongoing and she's one of the beneficiaries. I have not yet gotten an update of what has transpired. So in discussion, we realized that this lady had many risk factors in her that were against induction. She had a big baby, she had an IFD, and they did not do any workup prior to misoprostol induction. And also there was misoprostol overuse. They induced a term pregnancy with 800 micrograms of misoprostol. The patient had antenatally a low HB, and she was also a known TRRD with their issues, coagulation issues. They tend to have bleeding tendencies, some of them. And she also had a poor obstetric history of abortion, and long interpregnancy interval. Next slide, sorry. The missed opportunities in here, we see the wrong dose of misoprostol being given to the wrong patient. She had a big baby and was not worked on prior to the induction. A cesarean section was sanctioned at 2 p.m., but it took over 2 hours to access theater. There was an institutional delay. Patient took long to buy the theater items. And then there were no ward reviews after the Caesar was sanctioned. Probably the rupture would have been identified earlier. And there's no blood and no doctor's post-operative review until day 5. So the VVF was diagnosed 5 days later. It could have been iatrogenic. And complications, the woman suffered following the misoprostol overuse. She got PPH, got a ruptured uterus, and now suffering with an obstetric fistula, which was a large one, massive. And way forward, following this case scenario, we have, as a district, planned for a district mentorship on misoprostol use and dissemination of misoprostol guidelines, which are going to be conducted by me together with the ADHO MCH next week. We're also going to have a private partner engagement. It is going to be spearheaded by the ADHO MCH, but I'll also be part of it with their respective health sub-district in charges. We have Busoga North, Busoga South, and Busoga HSDs. We are starting a journal on post-operative care for management, and the in-charge postnatal is taking lead, and also a journal on PPH management, and the in-charge maternity is taking lead in that. And that is what came out of this case. We are lucky the mother was saved, but the baby did not make it. And we are not so sure whether she'll be able to conceive again. Thank you for listening.
So just to tell all of us that this is a new commodity that is in the new essential maternal guidelines that is basically and specifically for the prevention of PPH. Next slide. So in my introduction, we all know that PPH is preventable, and it is the leading cause of maternal mortality in both rich and poor countries like Uganda. And all women who are pregnant are at a risk of PPH. And of course, many women who survive PPH suffer severe morbidity. So we also know that the actual burden is grossly underestimated. Why? Number one, feasibility of accurate measurement in routine care is usually difficult. Another thing is existing measurement options have inaccuracies, and also the data on PPH is routinely not captured. So we see that whatever that we report is usually grossly underestimated. So the background, how big is the problem, the PPH that we are talking about? We see that the global burden of PPH is 5 to 25%. And then the prevalence per 100 women delivering, that is more than or equivalent, they lose more than or equivalent to 500 males. So when you see the statistics in this slide, it shows you how much PPH is a problem, not only in Uganda, but also to other countries. And also PPH is the leading cause of maternal deaths worldwide, which is responsible for 25% of delivery associated deaths. And then also 8% of maternal deaths is in developed countries. And of course, we also know that when women are referred from another facility due to PPH, most of them are likely to die. Next slide. So, okay, if we are talking about our country, what is happening with PPH? We see that 1 in 3 women have anemia in pregnancy. And we also understand that the risk of PPH when a mother is anemic is 50%. And then the PPH case fatality in Uganda is 2.3%. And also PPH is responsible for 34% of all maternal deaths that are reviewed in our country. So when we look at this slide, of course, I got some of the slides from the previous presenters because my presentation was a continuation of the other. So this was already discussed, but what do we see here? We see that most of the deaths are due to postpartum hemorrhage. You see that PPH is contributing 80% according to the graph, and then 20% is being contributed by APH. So meaning that PPH is still the leading cause of maternal deaths in the country. So the same slide, it is showing 6 leading causes of maternal deaths, that's by health facility level, financial year 2020-21. And we still see that PPH is coming up as the biggest contributor of maternal deaths at all levels, whether it is at health center 2 or it is at health center 3. Then when you look at health center 4 and above, the maternal deaths are due to multiple causes. So now we get back to our real slides. Like PPH is the leading direct cause of maternal deaths worldwide, and over 90% of deaths from PPH occur in low and low middle income countries. So when you look at this graph still, it's still explaining the percentages that these leading causes have. PPH, which is severe bleeding, is still scoring 27%, and of which out of this 27%, 73% is postpartum hemorrhage, meaning the problem is still there. So again, maternal morbidity due to PPH has a negative impact on women, their families, and the communities where they live. When a woman dies, we understand that the consequences of her death come in as physical, social, economical, and then psychological. So it means that we can have the immediate health complications, but we should not forget that also if a mother experiences PPH, there are high chances that she's equally going to have long-term consequences. And those long-term consequences come into her family, the community where she lives. There are also financial consequences and etc. So how do we overcome the heat barrier to prevent PPH? I already said earlier on that most of the deaths that are brought due to PPH is due to uterine atony, and we all know that this could be prevented. But the drug of choice that we have for prevention of PPH is oxytocin. And the current standard of care uterotonic, we know that it requires a sustained cold chain transport and storage, which is usually from 2 up to 8 degrees Celsius, typically in a refrigerator, to maintain its effectiveness. But this poses a challenge in many low and middle income countries where access to sustained cold chain may be readily available. We are all health workers here. And when we reflect back to our facilities where we work, you realize that sometimes we have the fridges, but you may not have the electricity. Sometimes the electricity is there, but then the cold chain is not maintained. So when you also look at this graph, it says that 99% of PPH deaths occurs in low and middle income countries where cold chain storage can be difficult, and Uganda is not exceptional. Then the current standard of care medicine for PPH, which is oxytocin, it needs to be under cold chain so that to maintain its effectiveness. And then also we appreciate and know that 22% of our health facilities surveyed across the countries, they don't have refrigerators. And for others, I told you that if the refrigerators are there, the electricity is not there. So what does that mean? It means that we still have a challenge with our oxytocin. The oxytocin may be available, but then we are not so sure of its potency because of issues connected to cold chain failure. So new solutions are urgently needed to prevent PPH in countries which face the highest burden. And okay, the solution that we are talking about here is a heat-stable uterotonic, which is heat-stable Carbetocin. And what is this heat-stable uterotonic that we are talking about? Number one, it does not need to be transported or stored at 2 to 8 degrees Celsius. It is stable for 48 months when stored below 30 degrees Celsius, but important that it should not be frozen. And then it does not require refrigeration, reducing pressure on fragile cold chain transport and refrigerated storage infrastructure in low and middle income countries like Uganda. So how is heat-stable Carbetocin different from oxytocin? Of course, we are saying that both of them are uterotonics, but this is the difference. Heat-stable Carbetocin is a long-acting synthetic analog of oxytocin that contracts the uterus. That is number one. The number two, according to the WHO recommendations that support the use of Carbetocin in the prevention of PPH for all births in contexts, where its cost is comparable to other effective uterotonics, Carbetocin is recommended in settings where oxytocin is unavailable or its quality cannot be guaranteed. And then also important to know is Carbetocin is added to the WHO EML, and then it is approved for prevention, only and only for prevention of uterine hemorrhage due to postpartum uterine atony, either following cesarean section or vaginal delivery. So in this slide, we are looking at the WHO recommendations that are for the prevention of PPH. So you see that the first recommendation that we have is the use of oxytocin. And then the next recommendation that we have is the use of heat-stable Carbetocin. Then we have misoprostol, then we have igometrin, and then a combination of oxytocin and igometrin, mixed dose combination. So heat-stable Carbetocin is a recommended uterotonic by WHO. So still in this slide, we are saying that the first recommendation is the use of oxytocin, which is recommended for all births. And then the second one is the use of heat-stable Carbetocin, which is 100 micrograms. I repeat, heat-stable Carbetocin is 100 micrograms, both for IV and IM. So it is recommended for the prevention of PPH. So still in this slide, we are seeing that heat-stable Carbetocin is included on the WHO EML, that is the essential medicines list. It comes as Carbetocin under uterotonics, and it is an injection which is heat-stable and comes as 100 micrograms, which is equivalent to 1 ml. So we are looking at, we have so many uterotonics, of course, but I think people are wondering, why am I really comparing oxytocin and then heat stable? Because it is the oxytocin that we have and it is the one that we know. But of course, we know that the challenges that are imposed due to oxytocin. So with oxytocin, we are saying that the class of drug that we have here is oxytocin. The example is oxytocin, and the mechanism of action, we say that it binds at oxytocin receptors and stimulates myometry or smooth muscle contractions. And now, if we look at heat stable carbetocin, it is a long-acting oxytocin analog. And then an example there is carbetocin. And what is the mechanism of action of heat stable carbetocin? It is the same as oxytocin, but here is the difference. The duration of uterine activity is longer. So the duration of uterine activity is longer. Remember my presentation, I'm really emphasizing on correct use. If we really understand how this drug works, it means that we shall be able to understand how this drug can be correctly used. So next slide. So what is the clinical value of heat stable carbetocin? It does, one, we say that it does not require refrigeration, and it can be stored for up to 28 months at 30 degrees Celsius. Then heat stable is given as a single dose, single dose, and easy to administer for the prevention of PPH. And then it is ranked as the highest single uterotonic agent for the prevention of blood loss. And then heat stable can reduce the use of additional uterotonics. In my presentation, you'll hear me emphasizing the word heat stable carbetocin is one patient, one dose, meaning that if you use it, you are not going to use any additional uterotonic. And then heat stable carbetocin and oxytocin have the most favorable side effects among uterotonics to prevent PPH. So what is the comparison? Now we are trying to compare the oxytocin that we have and the carbetocin. Carbetocin, as I said earlier, has a longer half-life and duration of action than oxytocin due to an increased biological half-life in plasma and effect on oxytocin receptor. That is something very important, that we need to know that it has a longer half-life, meaning that it has a longer duration compared to oxytocin. And then the uterine contractions last approximately 4 times longer than with carbetocin than with the one of oxytocin. Then when we come to the favorable safety profile, as the meta-analysis, heat stable carbetocin and oxytocin have the most favorable side effect profiles among the uterotonics. Doctor has been talking about misoprostol. Of course, we know that misoprostol works. But when you look at so many problems or so many concerns have been coming in about misuse of misoprostol. But here we see that heat stable carbetocin and oxytocin have the most favorable side effects. Of course, we appreciate that there is even no drug that does not have a side effect. But this carbetocin and oxytocin have the most favorable side effects, okay? And some of the side effects that we are talking about is usually fever, nausea, shivering, and then vomiting. Okay, then heat stable carbetocin is a long-acting and effective for the prevention of PPH. It has a rapid onset of action. And what does it mean? Within 2 minutes for both IV and IM administration, long half-life and prolonged duration of action. That is 60 minutes for a single IV injection and 119 minutes for an IM injection. And then also heat stable carbetocin can reduce the risk of uterine atony and excessive bleeding following a single IM or IV injection. And then oxytocin frequently requires low bolus IV injection or infusion. And then heat stable carbetocin is reliable as a single standard dose, once potentially making it simple and convenient to administer. So in this slide, you see that we are trying to compare the duration of action for oxytocin and also heat stable carbetocin. When you see the first one, when you give oxytocin, it is going to take a duration of 30 minutes. And then when you give carbetocin as a single dose, it is going to take a duration of 119 minutes. So heat-stable carbetocin indication, it is only approved for the prevention of uterine hemorrhage due to postpartum uterine atony. So this is important for me to re-echo. Heat-stable carbetocin is only and only for the prevention of PPH. And then it must be administered only after delivery of an infant. Of course, I've been emphasizing that heat-stable carbetocin has a longer duration of action. So if you administer it before the delivery of the other infant, you know what is going to happen. So it is important that we know that it is only and only administered after delivery of the infant. So contraindications, number one, it is not for augmentation, it is not for induction. You do not give it during pregnancy and labor before the childbirth. Then we don't give it in women with serious cardiovascular disorders, in women with hepatic and renal disorders, in women with epilepsy, and then in women with hypersensitivity to carbetocin and oxytocin. We do not give heat-stable carbetocin. And then, okay, here we have important warnings. The use of heat-stable carbetocin at any stage before delivery of the infant is not appropriate because of its persistent uterine activity, because it persists for longer hours. And then first, before you give carbetocin, please rule out the presence of another baby. And then also heat-stable carbetocin is contraindicated during pregnancy, including for the induction of labor. And please never inject heat-stable before the delivery of the infant. And then, of course, this is the composition and packing. It comes as Carbetocin Ferring, which is a commercial brand. It contains 10 ampules per box, and each ampule is equivalent to 1 ml, which is equivalent to 100 micrograms. So when it comes to administration, as I discussed, we said heat-stable carbetocin must be injected as soon as possible after the birth of the infant and preferably before delivery of the placenta. But please make sure that this is not a multiple gestation. And also heat-stable carbetocin should only be administered by skilled health personnel. Then for that bit of administration, it is also important to know that the solution in this ampule is for use when it is not undiluted. IV, because we know usually, of course, I'm trying to compare the oxytocin that we have. Usually when we are giving oxytocin, there are times when we put it in the IV bag or in normal saline or what. But for heat-stable carbetocin, if you're going to give it IV, you give it directly, it is not diluted. And then even if it is IM, it will also be given directly as IM. So here we see that heat-stable carbetocin is given as 1 ampule, which is equivalent to 1 ml, and 1 ml is equivalent to 100 micrograms. So it is 1 ampule, 1 dose, 1 patient. Okay, then for IV injection, we see that it is administered directly into the IV port. You don't have to dilute it, and it is given slowly for over 1 minute. So do not inject heat-stable carbetocin into the intravascular fluid bag. That is for IM injection. Of course, we all know how to give IM injection. It is administered still, it is 100 micrograms, which is equivalent to 1 ml. So when we come to the interactions of heat-stable carbetocin, we see that it can be administered for prevention of PPH, even if oxytocin or other uterotonics have been given during labor. And if bleeding continues, so it means that now you are no longer in the prevention. So it means that you're going to go into the management of PPH. This is something that is important. The moment you give heat-stable carbetocin and the first dose has not worked, it means that now you are no longer dealing with prevention of PPH. You're going into the management of PPH. And then you are supposed to follow our local protocols as per the management of PPH. So heat stable, it remains storage, it remains stable for 48 months if stored below 30 degrees Celsius. And also, it is important that you do not freeze. Then ampules must be kept in the outer carton to protect the product from light during storage. And also, just like any other drug, when you're administering any other drug, you need to look for the expiry date before administering this drug. So this is pharmacovigilance, of course, for midwives and any healthcare professionals. When you have any problem with the drug, please feel free to email this safety mailbox carbetocin@ferring.com. And then, of course, as I said earlier, this is a new commodity that is on the market. And now we are asking ourselves as Uganda, how far are we with this drug? I need to tell you that this drug, heat stable carbetocin, is approved by MOH, and then it is equally registered by National Drug Authority. And also it is included in the newly launched Essential Maternal and Newborn Care Guidelines. And then what are the plans? We intend to include this on the EML list of Uganda, because remember, as in my presentation, I said it is on the WHO EML as the second uterotonic that is used for the prevention of PPH. So as Uganda also, we are looking forward to including this drug on the EML. And the moment it is included on the EML, it will also be included in the UCG, then it will be procured by AMCHIP. And then we shall continue doing training on the correct use. And then lastly, heat stable carbetocin in summary, we are saying that this is a WHO recommended uterotonic for the prevention of PPH, and it is included on the WHO EML list. It has a longer duration of uterine activity than oxytocin. It is beneficial for use in PPH prevention, but heat stable carbetocin should not be used during pregnancy or before birth of a baby. Heat stable carbetocin and oxytocin have the most favorable side effects profiles among the uterotonics that we know. And then it is the only injectable uterotonic that can be stored in the approved storage condition at 30 degrees Celsius for 48 months. And lastly, it is one dose, one patient. So if you give heat stable carbetocin, please, you do not have to give another added dose. So I think this is my last slide, and thank you so much for listening.